I'm going to take only 10 seconds on behalf of the Group 1, and especially from my Argentine colleagues, in order to thank all the organizations that make possible to have this great global forum here in Buenos Aires, and also to the organizing committee, and to Florencia, especially to Florencia Luna for her dedication and commitment. So many thanks, Florencia, and congratulations. Well. The group included passionate and enthusiastic colleagues from Brazil, Chile, Ecuador, El Salvador, Guatemala, Honduras, Peru, and Argentina. The group has reached a consensus about the need and importance to do research in pregnant women due to the lack of data, especially in certain areas and countries with special considerations of certain safeguards. We also need to emphasize and try to put on the agenda, and not to exclude from the agenda, the ethical concerns that surrounds restrictive legislation in the context of Latin America and the Caribbean, as well as the inequities in access to health. We also identify the existence of ethical concerns and challenges when asking consent during labor. Although giving consent in the first visits will help adherence to the health team, we need to face the problem of women who do not access to health. There is also a need to overcome the gaps related to regulatory ambiguity and black holes, as well as how to translate the parlance of the guidelines to actions. Although there is a growing consensus not to consider pregnant women as vulnerable towards the purposes of the research, it is also of importance to define certain social vulnerabilities that may coexist during pregnancy, especially in certain contexts. Even though maternal and fetal interests are usually aligned, there are some circumstances in which these interests may diverge, especially in research not focused on concerns of pregnancy, labor, or fetal health. This, we have a special quote from acog.org. As there is an increase in the amount of laws in certain countries regarding the rights of adolescents to take decisions at the clinical care at early ages, nearly under 15, there is still a gap on what is happening in the research scenario. Due to an increase in adolescent pregnancy between 25 or 35% approximately, depending on the context, it's important not to exclude pregnant adolescents from research. It is also suggested to build capacities in the topic of research ethics in pregnant women, tailored to members of research ethics committees, researchers, healthcare professionals, which ultimately are who use the results of research to develop best practices. Although information might not be enough to change beliefs, it would be certainly of help, and not only information, but also access to information. And at the same time, it is essential to show respect to different cultures, but especially considering the tension that the term sometimes deserves. Well, and finally, a question whether, without denying the importance of safeguards to women as participants of research, perhaps we place a question whether we need to move from a protection paradigm to an access one. Thank you very much.
Our summary is the following. I hope I correctly got to summarize all the discussion that we have. So I think that there are 4 key points that we made. First, that we strongly support a view that pregnant women per se are not vulnerable. Pregnancy is scientifically complex and calls for protection, and research with pregnant women is ethically necessary, and we commit to advocate research with pregnant women with our own ethics review committees, our fellow investigators, and the health authorities. Second, ethics review committees play a key role to advance research with pregnant women and have the duty to do a thorough ethics analysis to safely include pregnant women in research. We had a lot of discussion about risk assessment, and we concluded that it was not possible to come up with any sort of algorithm that works in all cases for the acceptable benefit risk profile for pregnant women and the fetuses. And assessments should be done on a case-by-case basis, taking into account not only the best evidence, but also the standard of care and the alternatives. We should ask research teams to proactively and as early as possible produce studies like reprotox studies so that we can have useful data on the risks and properly assess the inclusion of pregnant women in research. and other mechanisms that facilitate collection and availability of data of risk and efficacy of interventions with pregnant women should be promoted too, so that, and made available so committees use them when assessing the studies. So number 3 is that research with pregnant women, and you'll see a strong regional component here, research with pregnant women is framed within the overall distrust towards research in our region. And this distrust towards distrust towards research in the region must be addressed if we actually want to promote research with pregnant women. So we concluded that we must proactively work to promote a positive perception of research among civil society and the government, because even in cases in which the government funds research, there's still not, the mistrust persists. We also concluded that instead of letting the media be the sole voice that provides information about research, we should consider doing the advocacy work for ethical research ourselves, explaining both the value of research and that research is, as it were, teamwork that involves the communities, and it must be responsive and inclusive of the needs of the community. We also discussed the need to enhance trust in research, promoting and strongly requesting that research is responsive to the needs of the communities, while at the same time and respectful of the diversity in communities, while at the same time advancing other strategies that enhance transparency in research. And our final point was that we acknowledge that a number of valuable guidelines, regulations, and literature are available and very useful for research with pregnant women and for other topics that are related to research with pregnant women, for example, risk-benefits assessments or community involvement. But our challenge in the region is to start using those guidelines, to implement those recommendations that are out there. We agree that inclusion of research of pregnant women is a learning process that starts with us, with our own ethics review committees, and that ultimately should aim at modifying and developing the political will that might be necessary to modify the regulations in the region. And the final comment in relationship to this is that we must get the lessons that we've been trying to learn lately since the Ebola outbreak actually learned in the region. Many of the things we're discussing have been discussed before, and somehow we just don't get ourselves to learn those lessons, and we cannot keep postponing that. Thanks.
Okay, so we had a very robust discussion on many different points. So first of all, to summarize, as an overarching statement, the group feels that it's unethical to exclude pregnant women in research that provides access to potentially effective interventions, especially when pregnant women and/or their infants are the ones who would benefit the most. And specifically for emergency situations, health professionals struggle in these settings of uncertainty in making the right decision. So we came to the conclusion that if endorsed by IRBs and deemed in the best interest of the patient, the option to participate in clinical trials in emergency situations should be provided and recommended to pregnant women, and the ultimate decision whether to participate should actually lie with the pregnant woman. So benefit risk assessment at all levels regarding the inclusion of pregnant women is generally made dependent on robust safety and efficacy data. However, what came across in all breakout discussions is that these assessments are heavily influenced by divergent cultural norms and perceptions, and therefore we think that community engagement is critical from the outset in enabling appropriate design and conduct of research in pregnant women. And this needs to not only include family and community members, but also health and field workers. So some examples were given where health and field workers actually conveyed conflicting messages to these women because they themselves had not fully bought into enrolling pregnant women in clinical studies. So medical staff, as well as policymakers, all the way up to regulators, need to be included in these community engagement efforts. Another key concept that emerged is gender, which needs to be addressed throughout the design and conduct of a study. So many, if not most, of the key obstacles or hurdles for enrollment were actually driven by gender-related factors. And in addition to that, in certain cultural settings, gender factors might also influence the community's perceived benefit risk assessment with regard to, for example, the mother versus benefit to, let's say, a male infant. And related to that, maternal blame in many societies was identified as an important factor which influences women's decisions in participating in a trial. So no matter what any potential adverse outcome might be, the mother is ultimately blamed. Very importantly, consent. I guess we've talked about this many times. We came to the conclusion that consent in pregnancy should be obtained as early as possible, but with the option to revisit later during pregnancy, including during labor. And for certain interventions or related to timing of enrollment as to when the pregnant woman for the first time accesses the possibility to be included in a study, obtaining consent during labor might also be acceptable. The final consent should be given by the pregnant woman, and we may need to accept a certain degree of compromise in autonomy of a pregnant woman, which again is mainly influenced by cultural norms, such as the need to engage other family members in decision-making. Members in our team who are directly working in these settings confirmed that these are cultural norms, and that it would therefore be acceptable to integrate them into the consultation and engagement, to integrate the consultation and engagement of other relevant family members in the consent and enrollment process. A very important aspect in designing and conducting trials is legal considerations, and sometimes legal criteria are not consistent with cultural criteria, such as the example given was the concept of an emancipated minor, which may hugely differ between different settings and cultures.
We're a bit over time at this point.
Okay. Quickly summarizing, lastly, manufacturers identified as major obstacles in being averse. So 2 suggestions. One is to adapt trial insurance to emergency situations. Secondly, a deeper engagement global health community with manufacturers. And lastly, regulatory guidance. Pregnant women should not be categorized as vulnerable populations, but as special or some other category to enable their enrollment and at the same time address their special needs.
This will be on 3 points. Many of the issues that were already brought up came up in our group. But the 3 points are sort of very broad and not very detailed or specific to particular issues. The first issue, and it affects all of us, is that we should learn to question the assumption that there is a good justification to exclude certain patients, pregnancy included, but always look at the reasons and the justification for exclusion. In other words, be much more vigilant about the exclusion criteria and their justification. We are invariably either researchers or members of IRBs or implementing research. And looking more carefully at the exclusion criteria may take much more effort, take us away from just doing things in a routine way, and may lead a lot more negotiation both with the IRBs, with the sponsors, and require more efforts to implement. But all 3 boundaries need to be pushed, and groups need to be woken up, and it begins with us. In other words, we need to become better advocates for our subjects and not just follow the routine requirements. We become our own worst enemy and we cannot complain if we don't do what we are essentially preaching. And the second point is that culture is often raised as an impediment versus something we have to navigate. And the real impediment or the real barriers may be ourselves and our willingness to navigate those waters and take the price of what it will entail. Those are the 2 points that I brought up, not repeating the others.
Like many of the other groups, we had a truly astounding diversity of regions and perspectives. So members in our group from India, Malaysia, the Netherlands, Zimbabwe, England, Botswana, China, Malawi, and the United States. And this proved to be such a source of what I would call group insight and wisdom. Like the other groups, we too had consensus and passion, I would say, around the need to include pregnant women in the research agenda earlier, often, and as a priority. We spend our time in group really talking about and drilling down on what does that look like in a given context. So making that translation from that commitment to what it feels like on the ground, recognizing that different contexts really can present starkly different scenarios than another. And I'll just give you our 3 examples that we drilled down on. The first is the concept of vulnerability. As other groups concluded, we strongly felt that pregnancy should not be defined as a vulnerable research group. As one of our members beautifully put it, vulnerability, vulnerable population, equals exclusion to the ERC, to the review committee. And much education needs to be done on this front. That said, we spent a lot of really helpful time talking about the fact that pregnancy can be a marker of deep disadvantage and disempowerment in given contexts. So we don't want it defined from in a legal perspective as vulnerable research population, but we do want IRBs and research ethics committees to be very, very mindful of the context of disadvantage that a given population might present. And so we endorsed Florencia Luna's beautiful layered approach to looking at participants' potential disadvantages. So first checking to see if they're a member of an official group like pediatrics, but then looking at the population in the context they belong in. Are there increased markers for poverty or domestic violence, or what kind of voice do those people really enjoy? The second is when we looked at the question about adolescent pregnant girls and women. So in much of the world, pregnancy really does happen early. And so confronting the ethics of research with pregnant women needs to confront what we do when pregnancy finds women and girls who are under the age of legal majority. And we really tussled with this question of emancipated minor. And once again, what I think was so helpful to our group was having some very different contexts represented at our table. So as one example, Botswana, the presumption when you see a girl who's pregnant under 18 is she didn't get that way by choice. So to regard her then as an emancipated minor might be problematic because she's already in a deeply distressed circumstance. She needs more protection, not less. On the other hand, in another context in India, in certain areas, early marriage under 18, right, like a 16-year-old, is not unusual. That 16-year-old may be more educated than her parents and running a household. So to just exclude her from the prospect of direct benefit doesn't seem right. So we didn't come up with a one-size-fits-all answer on emancipated minors, and might urge people to be careful of concluding that. The last one, the really interesting question about partner permission. So the group very strongly felt that the pregnant woman and the pregnant woman alone should be the final decision maker of whether or not to participate in research. That said, we sort of liked the phrase final decision maker rather than sole decision maker, even though legally they're the very same thing, because we do often, pregnant women often want to have a conversation with their partners and their husbands. And more importantly, perhaps, we want men to feel invested in a pregnancy and a child. That's good not only for the men and the children, but for the women themselves. So there was a wonderful example from Zimbabwe of a protocol that invited the pregnant woman, that gave her an invitation for her husband, that she would decide whether to pass on. That's the control in her hands. But that invited him to have direct engagement with the research team in a men-only setting so that you can make interested and supportive partners feel a part of the process and not excluded from the whole conversation. Thank you.
On the first theme, we started arguing about what is the unique challenges of pregnancy, and we would say that the most important thing would be at what point of labor a particular lady is, and it's more an issue of her competencies at that time, and that she shouldn't be in any pressure or should have any conflict of interest. Like as already has been discussed so often, culture does play a major role. In certain cultures, men may be with their wives, and other cultures may not come close. So it can pose some challenges. But that was on the first question. The second question, are they more vulnerable? It was a clear no to us. There's no special reason to say that pregnancy causes more vulnerability. However, we have acknowledged that some women may feel not empowered enough with all this responsibility of this future baby to take major decisions on their own and would like to involve their husbands or their partners or their family members. And then regarding to the risks and benefits of the question, we sort of came up with that one has to remember it's both the mother, the baby, and both. And so we haven't really in the end defined what limits it is, but it's really the risks that dictates what kind of research should take place. Coming to non-communicable diseases, we've spent a lot of time talking about the emancipated minor and really come to the conclusion the culture and the legal system of a country plays a major role in what is an emancipated minor. However, if we look at it from a universal perspective, an adolescent can be quite competent. However, we know that they are prone to risk behavior and may have poor impulse control, but that if they're clearly competent, there's actually no reason why they cannot agree to participate. So when we come to whether they should only participate when there's direct benefit, we came up with a conclusion that there's so many studies, observational studies, longitudinal studies and blood-taking studies where there's actually really less and minimal risk, which are being conducted, that you can't exclude anybody, and that what it's really about in that question is about the risk and what risks will be allowable. Coming to communicable diseases, we argued about autonomy as a relational concept, and again had to decide that the legal and the cultural and religious framework or context may influence this process. And it's very easy when a woman says no, she doesn't want to participate because then it ain't it. But if she says yes, we've come to the conclusion that that particular lady then has to decide who should be involved and whom she wants to assist her with that decision-making process. Coming to the last one about public health emergencies, we have addressed the question of how should regulatory authorities be prepared for future epidemics. And we thought that, in a sense, one should use past evidence to create policies for future epidemics, and that this is probably the WHO and National Research Ethics Committees, drug regulators, and so on that should participate in this process. And one of the issues that came up in the case study was a bottleneck with the manufacturer, and that there should actually be prior discussions with manufacturers to address issues like compensation and like insurance, so that one can make sure that it can take place. And then using the US as an example to use innovative ways of getting from the animal studies directly to humans in an epidemic when you know that you're now dealing with an epidemic. And one final thing that we felt very strongly about, that in actual fact there should be justification for excluding both pregnant women and children when there's an epidemic and a potential life-threatening disease, and that then companies and manufacturers should come and say why they really want exclusion for that particular group, rather than argue whether they should be included. Thank you very much.
So we circled back to 3 big picture themes through each of the breakout sessions, and those were really issues around consent. And interestingly, it got broken down into its component parts, so discussions about capacity and competence, discussions about disclosure, but with a particular emphasis on understanding, and some suggestions that maybe in certain cases you ought to actually have to check for understanding, and some discussion about what that might look like and whether that's appropriate just for pregnant women or whether that you'd then have to have that as a standard for all research participants. And so that would be around issues of respect for persons. And then beyond that, we cycled back several times to issues about access and recruitment. Again, and there the particular concern was issues of social justice and a pretty firm belief that pregnant women should have the opportunity to be involved in a trial. They may choose not to consent to do so. And then the third thing that we kept cycling back to, which really I think was a challenge for our group, were around the cultural issues. When and how to respect culture, and whether there are circumstances in which you ought to respectfully challenge culture. We don't have any sort of suggestions as to how that should be resolved, but as I said, we kept coming back to those 3 themes. And then more specifically, what I'd like to share with you is that we did have some comments around this issue of vulnerability. We agree with comments made earlier that they ought not to be sort of marginalized as a vulnerable population. There was some interest in the notion brought forward by Ruth with respect to CIOM's understanding of this as vulnerable being restricted to the idea that you're unable to protect your own interests. And that would have both an internal and external component. It might be with respect to issues of capacity, but it might also have to do with issues in this context of the cultural milieu. What we did agree with is that they're not to be marginalized as vulnerable, but they ought also not to be thought of as a special population if that just means special protection, and that there's a difference between special protection and special attention. Under the issue of special attention, we thought about issues to do with the fact that people should be presumed competent, and so we came back to the issue about research and labor and concerns about suggesting that because you're in pain somehow you've lost your capacity. Also in the context of the labor research discussion, real attention to the point that the phase or the trimester might matter significantly, that cultural beliefs that influence the way in which people and the places where people deliver can also have important influences on how one does research, and the timing of disclosure for us was a very specific concern. Second major point was actually around design issues, and that came up especially in this last question, last breakout group, where we talked about the value of having sort of some kind of an accelerated stepwise strategy to ensure that pregnant women aren't only getting involved in any kind of research activities when you're in the marketing phase for the rest of the population, that you've gone through your phase 1, 2, and 3, you're out there marketing, and now all of a sudden it's like, we'll rely on this promissory note that we're going to go back and actually do the research in pregnant women. However, there was concern that this may not be something that can work well in the context of a public health emergency, largely because you're not going to have the time for that kind of a strategy. And so we really need to look at that differently. And the way in which we thought about looking at that differently is to actually go back to look at some basic principles of public health and apply the basic principles of public health to this public health emergency. And there, what we typically have as priorities is a commitment to reduce mortality. And here's just a little interesting thing. The more people you include, the perhaps greater chance that you would have of actually reducing mortality. And also in that context, to think about relational accounts of public health ethics, where the focus is on us all, so the whole population. Third point, very quickly, were the benefits of a life cycle approach as opposed to a vertical approach, where what we are still stuck in then is how the woman is a vector of possible harm to her fetus, and that if you have a life cycle approach, you don't actually only start thinking about the interests of the pregnant woman when she is pregnant, you're thinking about her interests throughout her life cycle. And so it matters that she has access to good health care, nutrition, HPV vaccine, all kinds of things that have nothing to do with the moment that she's found to be pregnant and now all of a sudden is to be excluded or targeted. Two very quick last points. Some interest in developing a framework for decision making that could be of interest to ethics committees, helpful, and that largely had to do with one of our responses to cultural difference. Some people felt strongly that women are always the ultimate decision makers. Other people had thoughts that within certain kinds of cultural contexts that may be a shared decision making, and we need to think about that. And that brings us to the very last point, which had to do with community engagement and thinking about that in terms of public education generally, about research, why we do it, what the potential benefits are for a community, for an individual. And the idea there is that you would thereby be able to both facilitate and support decision making by the woman. Last point, we have a problem that we have no advocacy group for pregnant women. Maybe we need to make one, and maybe they can't all be pregnant women.
For those I've not interacted with so far, my name is Joanne Maluki. I'm from Kemri, Nairobi, Kenya. I represent the white group. We had a very active discussion, very diverse group. I think we were from 4 different continents. And we had very interesting discussion regarding these issues. I will briefly just mention the gaps and the challenges that we identified and the possible ways to overcome the challenges. The first one was a legal framework. Melba presented a very nice presentation on Ebola, and in some instances, the insurance companies were not willing to provide insurance. So we felt like that before the next outbreak occurs, maybe the stakeholders could approach insurance companies and ask them whether they would consider coming up with a policy when it comes to outbreak situations, that they can cover, outbreaks such that the pharmaceutical companies would be comfortable to recruit participants, including pregnant women. Hopefully that can increase the intake, the recruitment of pregnant women rather. And also the legal framework should be modified again to make sure that the pharmaceutical companies are comfortable recruiting pregnant women. We had the story of Nubia's mother who died, and if she had been recruited, maybe her life would have been saved. So I think we need to work on the legal framework to encourage pharmaceutical companies to recruit pregnant women, not just the babies, but also pregnant women. Now, I must be honest with you, before I came for this conference, I didn't realize how much of a disservice we were doing to pregnant women. And I've been pregnant 3 times. And, at that time, I had to go through my pregnancies with severe spring allergies. My doctor was not comfortable giving me my medication because he didn't have any safety information about it, and he didn't know whether it was safe for my baby. So that's when I realized this is actually, we're doing our pregnant women a disservice. And I think I'm not the only one who's ignorant to this fact. I think we need to sensitize our leadership in our countries, the people who drive the research agenda. They need to come to a forum like this to realize that we need to include pregnant women in these studies. I think it's really, really important for them to understand. And they can drive the research agenda in their countries, in their institutes. When I go back, I'm hoping to create a presentation and present it to researchers in my organization to just show them that we need to start thinking more than just non-pregnant participants. Now, I serve in a research ethics committee. Our practice has been, when we see pregnant women are being included in a study, we ask for a justification. Why are you including the pregnant women? Now, I think we need to change that. We as committee members need to ask, would you consider including pregnant women? Why are you not including them? Especially in cases where we feel that they would benefit from a particular clinical trial. For example, if it's diabetes, if it's mental health, if it's high blood pressure. And we can ask, why are you not including pregnant women, especially if they have the safety data in pregnant animals or non-pregnant women? They should consider including pregnant women, so we can start developing the safety and toxicity data so that in future our pregnant women can have access to these medicines and the doctors can feel safe in prescribing these medicines. So we also as committee members need to start thinking in that line. The other thing we felt that there's lack of empirical evidence in terms of what does the community feel about including pregnant women in studies. So I felt like social scientists should consider going out and conducting studies where they interview our pregnant adolescents, pregnant women, their spouses, the community members, community advisory boards, ask them, what do you feel? Do you think we should include women more? So that when we have evidence, we can push our agenda and say, look, this is what the community feels. I think we need to start thinking of including these women more and more. The community advisory boards could also be used to sensitize the community members, especially the pregnant people and their families, and tell them, look, just because you're in a research study, it doesn't mean the baby is at any harm. Some of them are very low-risk studies. For example, collecting blood from women who are already taking high blood pressure medicines. An extra 1 ml of blood to just assess toxicity will not affect them. So they need to go out and tell them, look, your baby is not at harm. It doesn't have to end badly. So another issue that we talked at length was culture. You heard today from Dr. Ngure in Kenya, our husbands owners. And the question came up, should research change this kind of cultural norms? And we felt that no, it's not possible to go into the community as a researcher and start telling people, no, this is not right, you should change this. So we felt that we need to embrace the cultural practices and ride along with them, because we cannot change them. If the men should be consulted, we should find ways of incorporating them. Sometimes the community itself doesn't feel like they need to change. We had an example of female genital mutilation in Kenya. We're trying to fight that as a country, but the women in the communities that practice it don't see what's wrong with it. So hopefully the next generation who are currently undergoing that practice will come, when they're adults, they will not want their children to go that. So with time, these practices might change, but I think we need to embrace them in our recruitment procedures. Thank you.